Thank you, Praful, and thank you everybody for joining in, particularly the experts who have joined, and Dr. Colin Wallace, who's going to enlighten us about contact lenses, and something, as I mentioned, was not so commonly taught and understood among residency programs and among practitioners, but I think it's a very, very key area for us. Thank you everybody for joining in, particularly the experts who have joined, and Dr. Colin Wallace, who's going to enlighten us about contact lenses. Right. So, small tech glitch. Again, welcome to all our panelists and experts. And this is just part of our big DOS teaching program, which instead of having one big program, which we hopefully will have, but we want to touch each and every of our resident, our young faculty, our practitioners, as many times as possible through the online system. And we start this session with this wonderful talk on contact lenses. Again, welcome everybody. And we hope to keep meeting all of you frequently throughout the coming year. So, Dr. Praful, I'll request you to introduce our speaker, please.
So, I'll share the PPT. So, before sharing that, I would just like to update you all. When we started this program, I was not much enthusiastic about the attendance of this program. But to our surprise, we have 700 registration for this program. And quite soon, I think Bhageswar will update us how many of our delegates are watching this live. And just to remind you, in the platform, only the speakers are visible. So don't think that only 16 participants are there. We are almost running 250 plus now. The 250 plus people have joined for the live streaming of this webinar. So to begin with, Colin Wallace, and he has a lot of experience on contact lenses over almost 35 years. And I think nowadays he has keen interest in scleral lenses in irregular corneas. She has worked as ophthalmic technician at Colorado Ophthalmology Institute, and she's been part of a lot of new protocols for contact lens fitting, special cases, all this thing. So I think we are quite pleased to have her with us. And besides her, there are a lot of panelists. So let me just go through the brief how we are going to proceed about this. First, Dr. Colin will finish her talk. Then we'll have a question answer session. And after that, we have a lot of discussion. Dr. Twinkle from Maharashtra, and Dr. Simi from LV Prasad, Dr. Varsa ma'am from LV Prasad. So we have taken panelists from all around India, so that we get a perspective of their what they practice about contact lenses and keratoconus. So let's begin with Dr. Colin Wallace talk first. Then we'll discuss our special cases.
Thank you very much for having us, and we're very pleased to join you on your Super Tuesday. We're going to share our screen here so you can see our slides. Sure. This one. This one. I have Troy here helping me share my screen. Okay. Are you able to see it?
Yeah. Now we can see.
Okay. All right. Thank you, Troy. So it's such a pleasure to be here with you all today on your Super Tuesday. We're pretty excited about this. It's a lot to talk about scleral lenses and the fitting process of scleral lenses and how far we've come with scleral lenses. We've our scleral lenses now, we've got the ability to make different quadrants, and there's a lot of learning here to do today on Super Tuesday. And I have with me Troy, who will be speaking later. He's our Vice President of Operations, and he's got an extensive background in the design and development of contact lenses and medical devices. He's been a design engineer now for over 25 years. He holds the position of Government Affairs, Technical Affairs, and the Regulatory Committee on the Contact Lens Manufacturing Board. So he's got a lot of good technical knowledge for you. But we're going to start with the management of scleral lenses on irregular corneas. Scleral lenses are the best option for patients who have keratoconus, who have high astigmatism, pellucid, RK, any post-surgical cornea, and even high astigmatic patients with no corneal irregularities. The benefits of scleral lenses are they don't touch the cornea and they don't move. So they're very comfortable for the patients. Patients always choose scleral lenses over glasses because they get much better VA out of the scleral lenses rather than their glasses. Patients that are post-surgical patients always talk about the comfort of scleral lenses and always choose the scleral lenses over their glasses, of course, because of the VA. The scleral lenses hydrates the cornea all day long. They're also made with a hyper decay material, keeping a lot of oxygen to the cornea. Scleral lenses vault over the cornea rather than rest on the cornea, keeping the comfort there for the patient. There's limited touch to the cornea, to the surface of the cornea, so that also helps with the comfort of the lens. And the lenses don't move, and they're like a big soft lens, and this is why they're very comfortable. Today's material is made with a very high decay, allowing a lot of oxygen to get to the patient's cornea. Patients always report that the #1 reason for wearing scleral lenses are the comfort. There's also good vision with scleral lenses. The tear layer under the scleral lens acts as power and fills in all the irregularities of the cornea, making the patient's vision much better. And the lenses seal off at the sclera, and that never allows dust and debris to get under the lens. So patients always claim that the scleral lenses are far more comfortable than a standard corneal lens, where dust and debris is always an issue and movement is always an issue as well. Together, the tear layer and little to no movement of a scleral lens ensures the patient will always have good, stable vision while wearing the lens all day long. It also helps with improved vision. The patients who can benefit from scleral lenses are patients that have keratoconus, any post-surgical patient, trauma, high cylinder, soft lens issues, post-RK. Most any patient can benefit from a scleral lens. Patients and experts all will agree the scleral lenses are the best option over glasses. Our freeform scleral lens are life-changing. Multifocal and astigmatic corrections are also available. We can make a front toric scleral lens if the patient has residual astigmatism that needs correction. Fitting scleral lenses can be a daunting task sometimes for new fitters. It's always best to follow the instructions in the fitting guide that's located inside the fitting kit. Our kit has 12 lenses, so it's not too many lenses to choose from. The fitting guide inside the kit is there for you guys to read it before you start fitting the patient. And that way you kind of know the ins and outs of how to fit our scleral lens. There are 3 simple fitting basics when fitting a scleral lens. First, you want the proper diameter. You want coverage and clearance over the cornea. And then you want a proper edge alignment. There's 2 different diameters in our fitting set. There's 15.9 and 16.4. Patients that have larger corneas, you want to choose a larger diameter lens. Patient with smaller corneas, you want to choose a smaller diameter lens. So there's 2 diameters in the fitting set, again, 15.9, 16.4. Patients that have a 12 millimeter cornea or larger, go with a 16.4 diameter lens. Patients that have smaller than that corneas go with a 15.9 diameter lens. The lens should always go approximately 2 millimeters past the limbus. The sag of the lens is determined on the corneal elevation. You never want the lens to rest on the cornea or rest on the limbus. There should always be clearance over the limbus, and the lens should always rest smoothly on the sclera. Our design has a very wide first width curve at the limbus to reduce any kind of limbal touch. So it's rare that you would put on a sclera lens, one of our sclera lenses, and have any touch at the limbus. The vault over the cornea should always be about 250 microns upon initial insertion. And that 250 microns you want to see at the steepest elevation of the cornea. If there's touch with a sclera lens, increase the sag 100 microns for every millimeter of touch. If there's too much vault over the cornea, more than 250 microns of clearance at the steepest point, then you want to reduce the sagittal depth in the fitting set. Choose a lens that's slightly flatter in base curve and sagittal depth. The edge alignment should always be nice and smooth on the sclera. You always want to look for any kind of toe in, heel toe compression. You also want to look for lift at any area of the sclera or at the contact lens at the edge. If there's lift, there's going to be room for bubbles to get in through the lens. A way to test for that is you can take a fluorescein strip, tap it on the front surface of the contact lens, and have the patient blink a few times. If you see fluorescein leaking into the lens, then you know that there's lift somewhere along the lens. Find out where that lift is. With today's technology, we can adjust every quadrant independently. So if there's only lift at 12 o'clock, we can adjust that 90 degree angle at 12 o'clock. We can steepen that area up. Using the consultants is very important. That's what we're here for. So the more information that we get, the more pictures that we get, the better the chances of a successful fit. So if you can take good notes, good pictures, and pass all that information along to us, it can be very, very helpful in the success of your fit. So just to review, always use the fitting guide. You always want the diameter to match the HVID. So for larger corneas, use the 16.4 diameter. For smaller corneas, use 15.9 diameter. When choosing a lens base curve out of the fitting set, you can try to use the 1 diopter steeper than flat K to choose your trial lens, and that'll get you close. It may not be the exact lens that you use. You also want to make sure that you have the proper vault over the steepest area of the cornea. And again, you want 250 microns at the steepest point of the cornea. If you have too much vault, your lens is too steep. So then you would reduce the sag by choosing a different lens a flatter lens in the fitting set. If you have touch, for every millimeter of touch, increase the sag 0.1. All of our lenses have an on-point grid system. All the trial lenses do. Patient lenses do not have this system. It's very important that when you insert the lens, whether you're fitting multifocals or spherical or front toric, insert the trial lens with the dot at 6 o'clock. The on point gives us the ability to decenter the optics for multifocals. So if you're fitting a patient that has the need for a multifocal, we can decenter the optics based off of the grid that's on the contact lens. To use on point correctly, the lens has to be again inserted with the dot at 6 o'clock. It should always be at the 6 o'clock position, whether you're fitting multifocals or a spherical lens. All scleral lenses sit down and out. So what that means is we want to know the lens is going to be decentered. So we want to know at what area the most hash marks are in the pupil. So in this example here, at 45 degrees, that's the area that the most hash marks are in the pupil area. So we would want to know that information so we can decenter the optics correctly. And your patient will be looking through not the center of the lens, but where we decenter the optics, and they'll have good, crisp, clear vision for their multifocal and for distance. The lens central ad zone is positioned over the pupil rather than the center of the lens. So when the lens goes down and out, we decenter the optics over the pupil. The limbal curve indicators are used to see if the diameter of the lens is a proper diameter. So the innermost limbal curve indicator should be seen at the limbus. If you have the outermost limbal curve indicator at the limbus, that means the lens is too small. So you want to go with a larger diameter lens. Always look at the temporal side of the lens when you're judging on the limbal curve indicators. The most inside curve, again, should be at the limbus, where the outside curve, if it's at the limbus, that means the lens is too small. You want to go for a larger diameter lens. You can use this method or just larger corneas, use a larger lens, a 16.4 diameter, or smaller corneas, smaller than 12 millimeter, use a 15.9 diameter lens. Scleral lens technology has come a long way, and we have the ability to make our Maxim 3D, which is a freeform design. And I'm going to turn it over to Troy now, who's going to talk more about scleral lens technology and how far we've come in this industry.
Yeah, Colleen at the bottom, if you'd start sharing the screen, then I can move into mine. It's a green button at the bottom.
Sorry. Okay.
All right, give me 1 second. Can everybody see that?
Yes. Yes.
Okay, fantastic. All right, thank you, Colleen. I don't believe I had a introduction, but again, I am the Vice President, Operations and Product Development. Today I'm going to talk about the scleral lens technology. It's advanced extremely quick. So it's not just for Aculens in general, but overall the industry, the advancements are tenfold over the last 5 years. The biggest advancement we had, other than the materials themselves providing more oxygen for the health of the eye, are the CAD systems and CAM systems available to manufacturers. Each scleral lens is designed using state-of-the-art CAD systems. Most of those CAD systems are three-dimensional, so we have the capability of forming a lens on the screen in the computer prior to even manufacturing the lens. So that allows all kinds of freedom in what we're going to do with final design. Each scleral lens is completely customized to the individual patient, so there is no stock system available for these types of lenses. They're not off the shelf. Everything is based off of either a trial fit or some of the newer technology in topography for scleral requirements. Freeform is also an advancement that's came in the last 2 years. Now, freeform is a completely different system where in the CAD, we design the lens to completely mimic the shape of the complete eye. That means not only are we vaulting compromised corneas, irregular shapes, but we're also aligning this lens to the sclera of the eye, which in most cases is going to have some sort of shape to it that is, for the most part, toric. And most of those are at least 200 microns different from flat to steep. The things that can be done with this technology, like I said, everything is custom, which means every part or every piece of geometry that is incorporated into the lens is custom for that patient's eye. Simple things like vaulting pinguecula or other anomalies have become commonplace with these designs. The CAD allows us to review that vault, where the vault is going to reside over a pinguecula. It also allows us to put fenestrations and niches in the design to help support more oxygen, easier removal, and all that is done through the CAD system. Another aspect of CAD systems allows us to do what we just talked about with Colleen, is offsetting the optics from multifocals. And it's not just multifocals. If a patient has a specific requirement because their visual axis is decentered from the center of the eye or center of the pupil, we can also offset optics to correct that issue. Extreme fits, again, with the CAD system, the material technology, and our ability to create a freeform. What this allows is high scleral cylinder shapes. Extreme shapes on the sclera always cause issues with a normal fit scleral lens. So what this allows is the ability to mimic that and match it. We also have the capability of providing prolate or oblate corneal shape coverage. And what that does is a flat cornea versus a steep cornea, we can match that profile, creating a better tear layer, better vision, and better comfort for the patient. All of this with extreme fits, we can incorporate what's called the AccuVault. The AccuVault can be positioned anywhere on the lens. In most cases, it's used for pterygium or it's used for pinguecula, but in some cases, like a filtering bleb, were to have some type of elevation closer to the cornea, we can create a niche that would cover that area and not allow any pressure on that filtering bleb. Using some of the newest technology available is key. It's advanced so quickly that we struggle to keep up with it ourselves, even though we're first in line for most of this technology. Profilometry is the biggest by far advancement for us. It's an advancement for the practitioner and for the patient. Two systems available currently are Eaglet with an ESP, which is probably the most used throughout the world for scleroprofilometry. Pentacam would be second to that, but just as viable. These systems are fairly easy to use. They do take some training and understanding how the systems work. But once you get through the training procedure and some of the finer points of operating each system to their own requirements, then the process is easy. It's easy as 1, 2, 3. You just take the photo, image processing occurs, and a 3D height profile is then available. That 3D height profile is what is specifically used to generate a freeform lens design. This freeform lens design is a mimic of the eye and the scan itself. So it's basically the similarities to this in molding a contact lens on the eye is so close that molding contact lenses on the eye is starting to go to the wayside just because of this technology. The ESP, we'll talk about that specifically since it's used widely throughout the world, is it provides us an exceptional amount of data. And the data you can see in the screen here, it can give us overall shape of that eye. Not only that, but it will pinpoint where a pinguicula elevation occurs, filtering bleb as discussed, or even double pinguicula. And in those cases, we can vault utilizing this information over each one of those areas. Another big thing with scleral lenses is the capability of providing the best optical correction. Those platforms that I like to call the scleral lens platform is the most stable provided in a contact lens modality. Utilizing multifocals is easier in this type of platform. High cylinder correction is easier. Aligning that with the eye is much easier. Utilizing on point is a huge advancement for centering these multifocal optics and increasing that possibility of success for the patient. Not only that, but HOAs are starting to become a big part of optical correction for patients, and utilizing a scleral lens as the platform makes that much easier, much more accurate for the patient. Again, multifocals starting to become a big part of fitting scleral lenses. It used to be that scleral lenses were not considered something you would want to fit on a patient in a multifocal optic. Well, it comes to the point now where these patients, even though they have compromised cornea such as PMD or keratoconus, et cetera, poor surgical, doctors were apprehensive. They were afraid to fit multifocals. The optical correction a scleral lens makes, to what Colleen said, is it masks the shape of that cornea. It fills in all the areas, creating a nice, smooth surface. So allowing patients to utilize a multifocal as part of that correction system is definitely something that you should think about. Established fitting guidelines. We have an extensive range of information on fitting scleral lenses, not just utilizing the technology of profilometry, but also fitting scleral lenses utilizing a fitting set. There's a lot of similarities, a lot of things to look for when you're doing both of those types of fit. And so the fitting guide establishes criteria for both and an understanding of what to look for when you have the patient under the slit lamp. I think that does it. If there's any questions. Are there any questions?
Thank you, Troy. I thought you are going to address those questions.
So you need to unmute yourself. Dr. Praful, you need to unmute yourself.
I don't think you heard. You are
Sir,
muted.
you need to unmute yourself.
Dr. Praful, you're not audible. Dr. Praful, not audible.
We can hear you.
Can't hear you.
Unmute.
I can hear.
Praful, we can't hear.
There you go.
We can't hear you. You were on mute. I think we can hear you now.
Am I audible,
Yes.
Dr. Pranit?
Yes, now you're audible.
Now you are.
Yes.
Now I'm audible.
Perfect.
Okay, so
Perfect.
let me introduce our chairs for today's webinar. We have Professor Rajesh Sinha, sir. He's an excellent corneal surgeon, and he looks after the contact lens clinic at RP Center. We have Dr. Sujata Das, again an excellent corneal surgeon, and ma'am is the head of LVPI eye banking network. We have Monica Chaudhary, ma'am. I learned my contact lens refraction from her only. She's again an alumni of RP Center. Now she's the director of MCVI clinic. And we have Dr. Aparna, and she's from Udupi. She's again a cornea refractive surgeon from Prasad Netralaya. So I would request all of our chairs, if they have any comment, any question, or any suggestion to make, then I'll sit down to my panelists.
Can I ask the question to Troy? Do you have any complaint like glare and halos like in multifocal scleral lenses? Do the patients complain?
Yeah, thank you for the question. Yeah, we do. The success rate in multifocals with scleral lenses is about, on average, about 20% better than what it is on soft lenses. However, that is limited numbers. One key factor is that with scleral lenses, doctors tend to try and correct much higher ads or try to incorporate intermediate vision and those type of things. So, and that stands to reason. These doctors are fitting compromised corneas. They're the experts in their fields. And so when they're fitting, they're trying to get the best result for the patient. However, with that platform, the outcomes are still, extremely high, considering multifocals in general not being that successful. I would say on average, 1 out of 2 patients, so 50% is going to be definitely successful. Key point to that is no different than any other multifocal, is you have to interview the patient. You have to understand what is the patient's requirements. What does the patient want? What is the possibility of the patient achieving those wants? I've been doing presbyopic correction, not just in contact lenses, but I've been doing it in ophthalmology, corneal inlays, corneal stromal rings, those type of things. And it's still, the results are the same. Interview the patient, understand the patient. That's the key component. Going from that point, since AccuLens would be an example, we have 7 different type of multifocals. So those interviews are extremely important. So when we make a selection on the optics that we're going to be providing for that patient, we're selecting based off of that. When it comes to directly answering your question about glare and halo, that factor is not just based off of the optics of the lens, but also what the brain interprets as the information coming in. Trying to do an initial fit on a patient with a lens that is progressive, not too distinct light points coming into the retina, but multiple disbursement of those light rays is the most important part for success initially. You may not achieve the highest ad possible with a progressive design in a scleral lens, but at least the patient will be happy and understand that there is potential for better reading. Today's world, most of that is done with progressive because most patients are utilizing intermediate vision more than they are using up close vision. Cell phones, iPads, those type of things are what's important for patients. So to answer the question, there's going to be glare and halo if you're not selecting the proper optic.
Thank you.
Mm-hmm.
May I ask a question? I'm Varsha here.
Yes, ma'am.
So this is about there are various designs in the AccuLens. So which one you prefer, and how easy or how difficult for the patients is to get adjusted to multifocal lenses?
The one we recommend 99% of the time is to fit the patient OU in a progressive multifocal. That progressive multifocal is aspheric front and back. It provides approximately plus 175 ad, which is for the most part intermediate. That is considering that the patient no longer has any accommodation whatsoever. Patients that have accommodation, it works even better because then they still have the capability of bringing in plus a quarter, plus a half through their current accommodation. So across patient ages, I would recommend that 99% of the time OU. Going from that point, I would then start to dive into fitting based off of on-point optical position and getting strictly focused on a center near ad.
Thank you. There is another question I have. How much time it takes for anyone to do the fitting? Because somehow I was unable to hear if you have to discuss that. For these multifocal lenses, how much time it takes for anyone to complete the fitting process?
It's always recommended to initially fit the patient distance. With scleral lenses, especially in a compromised cornea, it's recommended first fit patient. Make sure the lens is stable, comfortable, and distance vision is where it needs to be. Then discuss and educate the patient on what a multifocal will do, what it will not do, understand, again, the interview process with the patient. And then from that point, request multifocal optics. So really the fitting process is no different. The time it takes to fit a patient with a comfortable lens, good distance vision, is really what we're looking at. Putting them into a multifocal, the fit isn't any different. It's just a matter of changing the optical path for that particular patient.
Thank you.
Ask a question. You said it's a 50% success, as I heard so. So suppose the lens is ordered and the patient is not satisfied with the multifocal. Is it again an option from Aculens to shift this back to a single vision lens back again to just a distance vision if that has not happened? Because it's
Correct.
really challenging if it is a failure in that respect.
Yes, and that does happen, yes.
And just a side note, whenever ordering multifocals, it's really important that we get the patient's age, the dominant eye, and then the ad power also, so we can incorporate that into the lens.
So what ratio of your patients in your country and all opt for a multifocal? Because here we rarely find somebody who's essentially looking for a near correction. They're happy to use glasses, reading glasses over the lenses. The cost is one of the prohibitive factors in India for our patients to afford that. We may have certain once or twice who are really looking for that. What percentage of your patients do you think are opting for multifocals?
I think the numbers that we pulled last year was approximately 15%. And again, it's a combination of two things. If the doctor initially, and in some cases the doctor does, they initially order the lens in a multifocal for first lens fit for RX. So it's starting to become more of a comfort factor for the practitioner, not so much the patient's understanding of that. And that 15% really is a group of doctors. It's not often we have a brand new doctor coming in that's utilizing scleral lenses for the first time, or at least our particular scleral lens, and ordering that right away. But we do find a lot of doctors that are successful in that 70% range, that they're actually ordering that on the first lens fit.
And I believe
Does that answer your question?
Yes, thank you.
Okay.
the success is also setting the patient's expectation, as long as they're not expecting perfect.
It's all about compromise. Yeah.
I had a question, sir. While before you fit a multifocal contact lens, is it important to examine the patient's retina and do a macular OCT and to rule out any macular pathology before fitting a multifocal contact lens?
Yeah, that's actually, I would recommend that prior to fitting any scleral lens, to be honest, because you need to always consider those type of things, early onset cataracts, etc., compromising vision. With a multifocal, that's exacerbated even a little more because we're providing multiple light paths onto the retina. So any disruption in any of that, that's spread factor, spread function is going to cause an issue with a patient. And at that time, they're going to either lose contrast in their intermediate near vision, or they're going to basically have glare and halo even throughout the day, not just at night.
Thank you, Twinkle, for that questions. We have few special situation by few of our discussions. Dr. Simi from LB Prasad, Hyderabad, Dr. Ikeda from Gangaram Hospital, Dr. Rakesh Gupta, he is director of Sriya Eye Center, Dr. Anu Malik, she's an assistant professor at RP Center, AIMS, New Delhi, and Dr. Neha Silpi. Could you please ask your special situation or any questions to our experts so that the audience can learn from those special cases? Dr.
Hi.
Simi?
Yes. Thank you, Dr. Praful. Troy, I have a question for you. And it is for the feature that you have, which is on point. So what we are trying to do using that feature is trying to change the optic zone from the periphery or from eccentric location to the center. So most of the times, or most commonly during a scleral lens fitting, we find that there is an slight inferotemporal decentration. So in that case, when we find that the optic zone might be slightly decentered, in that case, do we have any limit to which we can use the on point feature to bring the optic zone to the center? I can't hear you, Troy. I'm
Troy, you're
sorry.
muted.
Yeah.
There we go. Let's fix
There you
that. Typically, we don't offset. This is for distance vision correction. Typically, there's no need to offset that zone, even though the lens is decentered out of position. And the reason is because the optical zone is at least 9 millimeter.
Yes.
With an optical zone at 9 millimeter, even decentering 2 millimeter, the patient's still going to have optical correction within that area. The only caveat to that is that sometimes it'll induce HOA, high order aberrations. Those high order aberrations would be induced because now we're actually in reality inducing prism into that lens if it decenters too much. Most of the time, though, we don't find that to be an issue. It's a very rare case where we'll actually go in and decenter the distance zone itself. I'd say it's less than 0.1% of cases. So for us, out of 10,000 eyes, you're maybe going to have one patient that we have to do that with.
All right.
But it can be done. I mean, it is part of the process if that's something that's necessary.
Okay, thank you. And a few more questions. What is the minimum diameter and the maximum diameter that is available in Aculens?
There is no minimum or maximum.
Okay.
Each lens is specifically designed for that patient. The only constraint that we would have is the material provided to us. The maximum diameter is going to be 20.5 millimeter.
And is there any limit, upper limit for sagittal height? Or for the
part of that is based off of geometry. Most of the time, if we find that sagittal height itself is exceeding the tooling limitation of the machine itself, that means the capability of a tool going in that far without causing other issues with the manufacturing process, we'll redesign the lens to a smaller diameter and still achieve the same outcome for the patient.
Okay, thank you.
Thank you, Dr. Simi. Dr. Ikeda, do you have any questions for our experts?
Yes, hi. I would like to ask a question. Actually, I have two questions. One is for these Aculens multifocal lenses, is there an adaptation time where initially when we fit in the lens, the patient might experience glare and halos, and then the patient becomes comfortable?
So comfort is a separate issue. Are you talking comfort of the overall lens or comfort through the visual process?
In terms of the visual process, in terms of glare and halos.
Glare and halo typically will come into issue with a lens that is a center near ad or a lens design that is alternating zones, because there's distinct separation between the add power and the distance power. Normally, that's what creates glare and halo. It creates a diffraction of the optics coming into the retina. Progressive correction through multifocal, very rare would we ever get glare and halo. I would say less than 1%. So it comes to the ability to interview the patient. Are they using their computer a majority of the day or their cell phones? If they are, progressive optics is the best. It disperses the light evenly. If you find a patient really requires that near vision because they want to see up close without putting glasses on for that extra half to 1 diopter, then the possibility of glare and halo definitely increase because splitting of the light. So it always goes to what is the patient expectations? What do you feel is the best for the patient? And trying to avoid that situation by promoting a progressive optic, making the patient happy, at least intermediate vision. So, to answer the question, it's difficult to say what the lead time is for that patient to get comfortable. Some patients, it happens right away, 15 minutes in the chair. Some patients, they get used to it after a week, and then some patients just don't. And then that becomes an issue. It's not so much the optics coming into action with the optical system of the eye, and it's the brain not being able to interpret the information correctly.
All right, thank you. My next question is also that when it comes to these distance scleral lenses and extreme cases of ectasia or extreme keratoconus, more advanced cases, do you have a criteria for the minimal corneal thickness under which or beyond which you would not fit a scleral lens for patients to avoid corneal edema or say high drops in these patients?
Initially, I would say no. You probably won't observe anything until after the fit. An example, if the cornea is just too thin and the epithelium itself just will not thicken like it should on these type of corneas, and you end up with consistent staining over the thin area of the cornea, then you're probably better off not fitting the patient, just because then you got to start incorporating steroids and all types of other things in order to correct that issue. So if a scleral lens doesn't correct that issue and it doesn't go away on these thin corneas, then I'm not sure exactly how many options that patient would have at that point. And normally I see when we have patients in the chair about 200 microns. If it's in that range or thinner, then you definitely are going to have epithelium that's staining, that isn't healing, that isn't thickening like it should on the thin cornea.
Thank you, Dr. Ishida. Dr. Rakesh, you have anything to ask?
Yeah, Troy. I have a question because I have a patient of very advanced keratoconus, and I think he has been operated with cataract with a toric lens, customized toric lens with a -11 power toricity. And now patient is not satisfied. And somewhere he was operated for with toric IOL, and patient vision is not improving beyond 624 parts. So if we try scleral lens in such patients, so how that toricity of IOL is going to disturb the vision, or how to tackle such patients with scleral lenses?
Yeah, there's two parts to it. If the cornea doesn't really have any inherent cylinder itself, I would assume all that cylinder, because of the toric IOL, that was probably residual. Is that correct?
Sorry?
Was the toricity, the need for the high cylinder correction in an IOL, was that cornea or was it posterior cornea?
It's cornea. Basically, the pentagram has been showing a toricity of -14 diopter right now, and a patient was implanted with -11 cylinder 4 years back, and it's difficult to say whether it's like I have a choice to rotate the lens or to give a scleral contact lens. So no, it's 4-year-olds, and it's a plate haptic hydrophilic lens made in India lens. So I mean, do you advise to go and rotate lens, try to give a better vision, or scleral lens can help this patient?
The scleral lens is going to help the patient. Well, the first part is that when the scleral lens goes on, any of that cylinder issue that's on the anterior side of the cornea is, for the most part, going to be resolved. Whatever cylinder correction is required for posterior side of the cornea will be incorporated through your over refraction. So it may take several lenses to understand the rotation of the lens and where that cylinder should reside with a lens on the eye. The only caveat to that is the axis on the cylinder that's on the anterior side of the eye versus the rotation of the IOL position in trying to correct that cylinder. More than likely, that's why the patient isn't happy, because the axis of the IOL doesn't match the cylinder axis on the anterior side of the eye.
Yeah,
but it can be done. Yeah. Did that answer the question?
So, my add-on question is that the toricity on the IOL, how will scleral lens? For example, I believe that if you cover up the anterior toricity with the scleral contact lens, then the toricity on the IOL, for that we need to give addition to the patient or on the glasses, or cylinder in the glasses, or will that not be required? Any kind?
No,
experience?
when you trial fit a patient, you're trial fitting a scleral lens over the cornea. It's going to mask most of that cylinder that's in the cornea itself. When you do that over refraction, what's coming through in that over refraction is the IOL cylinder, or the offset from what was initially anticipated to correct the overall corneal cylinder. So once you do that, it's masking that surface. You're doing it with a spherical lens, so single vision. Then that over refraction is really going to be what's coming through as, what we refer to as residual. And that could be a combination of the posterior cornea cylinder and the IOL, but it still would be, 90% correctable.
Okay.
Thank you. Dr. Anu Malik, do you have any questions to ask?
Yes, sir. Thank you, sir. Sir, I would like to know, in patients who have undergone corneal transplants, as they have irregular astigmatism as well as variable graft host junction, so fitting standard contact lenses can be difficult in these patients, and moreover, RGPs also get decentered. So what design would you recommend for these patients, and what all lens parameters need to be adjusted in these patients?
I would utilize a scleral lens for that patient 100% of the time. Most grafts tilt in some direction. Most grafts are going to provide a need for a cylinder over refraction. So a scleral lens will mask most of that tilt, and you'll have a lower cylinder correction required in the lens itself. But the biggest factor is the scleral lens can vault any of that area. So it's not going to compromise the host junction typically, which is about 7 to 8 millimeter. And so it's going to raise above that and not going to cause any issues long-term for that patient. So that's the lens that I would always recommend. To be honest with you, I'd never recommend in today's world, I never recommend a gas perm corneal RGP because of the possibility of it just never making the patient happy, and probably not making you happy, because every time the patient comes in, there's some staining somewhere because epithelial rubbing. So that's the recommendation.
Just to add on here, I think we have a question by Dr. Sabba Inamdar. Exactly asking the same question. In the era of scleral lenses, what is the role of RGP lenses? I think Dr. Troy, you answered that well. If patient is ready to use scleral lenses, I think that is the preferred one.
Correct. Yeah. There's definitely room for corneal GPs, without a doubt. They're easier for a patient to take in and out. They're easier for a patient to clean and take care of. They're less expensive. So, you really have to assess the situation. If the patient is just a moderate cone, there's nothing wrong with fitting that patient with a corneal GP, and making it much easier on the patient, probably yourself as well. But there's no reason to shy away from that.
One related question is if patient has undergone trabeculectomy, right? So there is some irregularity on the scleral surface. So in those cases, would you prefer scleral lenses or you would go for RGP lenses?
Could you repeat the question again?
In post-trabeculectomy cases where there is a bleb, so in those cases, how to go about scleral lenses fitting?
I'd initially fit them if the corneal geometry allows it. I would initially fit them with a corneal GP. If it doesn't, let's say that patient has a compromised cornea in some fashion, it's a regular shape, then I would go to a scleral lens and just indicate where the filtering bleb is or where the anomaly is. Once that information is given to us, then we'll do an AccuVault or a niche in order to get over that.
So Dr. Neha Shilpi, she has joined from Varanasi, and she is an excellent corneal surgeon. Dr. Neha, do you have any questions?
Yes, sir. Thank you, sir. So, yeah. So I just want to share a situation which we commonly come across. So there was a patient of advanced keratoconus in which we were doing this corneal lens fitting, and the base curve and the sag height we chose was as per the recommendation. The fitting went really well. The vision improved from 3/60 to 6/6 partial. So initially everything looked good. Fluorescence staining and everything looked good. But after, when the patient was waited for 30 minutes, after that we could see blanching at the periphery. That was not very much, not very prominent, but there was some blanching. So we flattened it. We increased the landing zone from L7, which we had initially used, to L9. So we did that, and with that also the vision was same. The patient was more comfortable. So I would like to ask, anything else that we can do in these cases?
Pay close attention to the amount of coverage over the limbus. If the amount of coverage over the limbus is excessive, lens is going to tighten down. You probably will end up with redness around the limbal area. It'll almost mimic a lens edge that is too tight. You'll probably have prolapse going up over the limbal area. So the key factor there is to reduce limbal coverage, to try and get it closer to the 50, 75, 100 micron level. A lot of times we see in scleral lens fits, the doctor's fitting a lens that is too large. The lens being too large is providing too much coverage and clearance over the limbal area. So photos coming back from the practitioner, the edge looks like it's impinging or compressing and pushing tissue up over the limbal area, when in reality, the limbal curve, which is what we refer to, that curve needs to be flatter and decrease the amount of coverage over the limbal area. That would be the only other suggestion I would have looking at that, if edge alignment looks to be fine.
Okay, thank you, sir.
Does that answer the question?
Yes, yes, sir.
I think she is satisfied with the answer.
Yes, yes, sir.
I think I will add, when the fitting is done in India, we should wait for 3-4 hours with the trial lenses. It's not half an hour job, actually.
Yes, no, yeah. We usually wait for 3 hours, but then in the initial assessment only we could see blanching. In the initial half an hour assessment, we could see that blanching. Then we thought that we should give another trial, because this lens, with this blanching, probably the fitting is not perfect.
So we can customize, order, and then the first lens, after 2 weeks of wear, the first follow-up is the key actually. That's when you ask the patient to come with 4 hours wear. And then when you remove the lens and you see these staining areas, that actually tells you what's going wrong with the lens, at which area and which point. So our perceptions are actually the aftercare, which is the first follow-up visit. With the first lens that you have designed, you can then have a second lens, which can be further customized for this patient based on the first follow-up.
Yeah, and I think we all know, we all agree that each patient's, and when it comes to scleral lens fitting, each patient's conch, their sclera, the tissue, in some patients, the tissue is fairly rigid, doesn't have any movement. In other patients, it's very pliable. So definitely, you could have one patient versus the other after 20 minutes to 1 hour of wear exhibit the exact same fit. They both look fantastic. But sending the best process at that point is sending the patient home. 2 weeks follow-up, or even 1 week is typically sufficient. They come back, a patient that has very compliant tissue could then have touch where the other patient does not, or they could have excessive blanching or heel in or toe in. So it's, yeah, definitely that 1 to 2 week follow-up is the most important part. Understanding every patient is different.
Thank you. We have Dr. Deepali joined us from Mumbai, and she's a director of one private institute. Dr. Deepali, you have any question to ask?
Yes, sir. Thank you so much for inviting me. So I had one question that most of the patients of keratoconus also have associated eye allergies and VKC. So in those patients, what do you recommend? Like, does these lenses have any complications or any other problem which you must have observed?
I don't believe so. I mean, sometimes the material is an issue, so you have to change materials. I don't know, Colleen, have you
No, I've
experienced
not
any of that?
No, I haven't experienced that or witnessed any of that. I think that most patients are fine, but like Troy said, the material sometimes can be an issue. And we have a variety of materials to choose from if it is an issue.
Yeah, allergies don't seem to be an issue. And here, I mean, we're in Colorado, and that's a high amount of allergies here. And I don't believe with the lens covering the eye completely that's really been an issue.
Actually, in India, it's a big problem.
We have a lot of
Yeah. Half of the patients of keratoconus that we see, they have this vernal keratoconjunctivitis. So I'd request our Indian panelists, Dr. Monica, Dr. Sujata, Dr. Rajesh Sharma. So what's your take on this question? Since the patient is having VKC, and would you go for contact lens? And if scleral contact lenses are better than RGP in such cases? Varsha ma'am, Dr. Monica, Dr. Sujata, anyone?
So in VKC, the question is actually VKC you're asking.
Yes.
Yeah. So I think the indication of a scleral is in VKC, and certainly it's success stories in such cases in my reference, I would say.
So as compared to corneoscleral, you will always prefer scleral if the patient is affording, right?
No. The corneoscleral, which is the rose K lens, is again a good choice, but these VKC patients have more secretions and mucus coming out. So the corneoscleral lens has a tear exchange. In fact, the proper scleral lens is the ideal for VKC patients because you'll have fogging otherwise in the patients with the papillae and other conditions.
Okay, so
Thank you, ma'am.
Blurring of vision is not seen in the scleral lenses, right? So
in fact, it is, if there is any leak point and these eyes are so much secretory things coming out, the debris would be there. It can actually, so corneoscleral is typically no for VKC patients.
Okay.
Thank you, ma'am. We have panelists, Dr. Bhupesh Singh, Dr. Ritin, Dr. Jeenu Priya, Dr. Sunandini, who all are running successful cornea practice. Any questions from them?
Dr. Praful, I'm sorry, but can I add to the discussion that we are having? So, Dr. Deepali, as per my experience, we actually fit a lot of patients who have VKC along with keratoconus. And they are those patients who typically initially were using RCL, so RCL's rigid corneal lenses. And because of the small diameter, these lenses do interact with the lid. And those VKC patients who have palpebral form of VKC, they will be very symptomatic to the rigid corneal lenses. So those patients, if you see and you plan to shift to scleral lenses do turn out to be very, very useful to these patients, both for symptomatic improvement, reduction of the symptoms of eye itching and eye rubbing, and also provide visual rehabilitation. So if you actually see those patients, scleral lenses are actually blessing for them, particularly those recalcitrant VKC patients where you are unable to control with medications.
So after the VKC is controlled, only then you must be prescribing the lenses, right? not in
So
active.
in those patients who have very recalcitrant type of VKC, it's actually you will never be able to, or it's very hard to find a stage where the VKC has completely come down. So all that we intend to do in those patients is to reduce the surface inflammation. As long as you can do that, the debris that Dr. Monica was talking about, the midday fogging, you can actually bring that down as well, along with reduction of inflammation. And with that, you can actually send the patients for scleral lens fitting. All that we need to reduce the surface inflammation is so that the patient is cooperative enough for you to go ahead with the trial.
Yeah, sure. Thank you.
Dr. Rajesh? Acha,
Yes,
Gino,
sir.
yeah.
Good evening, sir. Thank you, first of all, for giving me this opportunity. I just wanted to ask about their views on corneal scar remodeling with scleral lenses. How often they see it and how useful it is. Corneal scar remodeling in cases with the use of scleral lenses.
Dr. Colleen and Dr. This question is directed to you. Do you ever see, do you have ever noticed any corneal scar remodeling with corneal scleral contact lenses, right, Dr. Ginu?
So repeat the question. You're asking about corneal scarring from the scleral lens or vaulting over a corneal scar?
No. In a case of existing scar, do you see any corneal scar remodeling with the use of scleral lenses?
No, we fit a lot of patients that have corneal scars. Just as long as you're vaulting over the scar, then you'll be fine fitting a scleral lens. Oftentimes, when you don't vault over the scar, it's an elevated portion on the cornea, so you have to still vault that area, the 250 microns. Even if that's the most elevated portion of the cornea, you still want to vault over it.
So what is the success rate in cases of corneal scars with scleral lenses?
Very good. It's very good.
Thank you.
Yeah, you have to, I'll interject here a little bit. You have to keep in mind, scleral lens is masking just about any anomaly that's on the surface of the cornea. In addition, it's also correcting some of the higher order aberrations because of that. But to answer the question directly, I have never seen in any patient there's been any type of remodeling of current scars. You know, it definitely corrects the vision and keeps any issues happening if you're vaulting over it correctly, but I've never seen remodeling. I'm not sure that's that would be a factor that even though the lens acts like a bandage lens in reality, I've never seen that.
Thank you, sir.
I'm Dr. Rajesh Sinha with us.
Yeah.
And sir is probably the most experienced clinician at RP Center, AIIMS, New Delhi, dealing with contact lenses and keratoconus. So what's your take on this? One is, have you ever noticed any corneal scar remodeling with contact lenses? Second, your experience on VKC.
Yeah. Praful, I'll come to 4 or 5 points that have been discussed. So I was just about to speak in between, but I could not because of some reason. So actually, first thing is the corneal scar remodeling or corneal topographical remodeling. That's what she meant. With scleral lenses, the corneal topographical remodeling usually is not any significant. So it's more often seen with the corneal lenses, not with the scleral lenses. Point number 2 is VKC. VKC, if it's a significant VKC with cobblestoning, none of the lenses will prove to be good and the patient will have a lot of symptoms. But once it starts resolving, and you can see that these are not elevated cobblestones, rather thickened scarring kind of thing is happening. But still, in such a little few papillae, in such cases, still these corneal lenses may not be good. But in such cases, scleral lenses, they do very well. They fare well, and the patient's acceptance is very good. Another thing that was being discussed was about the bleb. With a bleb, even if you fit any kind of a lens, if it's a corneal or a scleral, it can cause damage unless you have a specially designed lens. There are lenses which are designed for bleb. These have notches. with each blink, which always remain there in the area of the bleb. So the fit is seen, and then accordingly the notch is prepared. So this is again a customized lens which is made for bleb, eyes with bleb. Another issue that was being discussed was, which was raised by Dr. Rakesh, which I was listening, that somebody having advanced keratoconus, toric IOL has been put, and minus 11 diopter of astigmatism is there. Such patient will never be happy by any lens, either scleral contact lens or a corneal GP lens. So such patients are not at all good patients for contact lens fitting, because these mask the irregularity of the cornea, and you already have fitted an IOL with a cylinder in it, which is already trying to mask some degree of corneal cylinder. So that creates a very bizarre outcome, and the patients are never happy. But yes, you can see to it that there can be some improvement by doing some trial method. Any other issue which was discussed, Praful?
Would you, on that point with the toric IOL, would you recommend glasses to correct the cylinder rather than putting that cylinder in the contact lens?
Yes, we can put cylinder in the contact lens. That is a better option, because 11 diopters of astigmatism, wherein a toric IOL has been put, and now in refraction somebody is getting 11 diopter astigmatism. Such patients are usually never happy. You can't give glasses with 11 diopter of astigmatism. So the only option left is with contact lens and putting cylinder into contact lens. But then these cases of advanced keratoconus, which have such an irregular cornea, are not very happy when they have been, if they are virgin eyes, not fitted with any IOL, any toric IOL particularly, then in such cases, these lenses do very well. And that is why the standard teaching that we do, and we have learned, is that if we have a case of keratoconus which is advancing and there's a cataract, due to some reason you have to do a cataract surgery, it's better to fit a spherical lens and don't go for a toric lens, because you can fit a GP lens, a scleral lens over it, and that will provide a very good outcome. So this is what I feel, and this is what we have noted in many of the cases.
And then back to the bleb, we can certainly notch a lens to go around the patient's bleb. We can customize any size notch in our contact lenses.
Absolutely.
Thank you, sir, for summarizing all the discussion point that we had. Dr. Sunandini, Dr. Ritin, Dr. Pranita, do you have any questions or points to make?
Sir, I have 2-3 questions I wanted to ask. I think one of the point sir has already spoken right now, that if it is a young male or young child who has undergone a cataract surgery because of steroid or something. So my question is, in this patient, as sir suggested, that we should implant as spherical lenses and not at toric lenses. But after that cataract surgery, when it is a young male or young female, so after cataract surgery, can we implant maximum 3D lenses at multifocal lenses, and how should we do, and after how much time should we do it?
See, in the case of a keratoconus, multifocal lens is a big no. So we should not think of multifocal lens. And most of these cases of keratoconus, what happens, why a patient develops cataract? Either the patient is having a VKC, getting steroid for a long time, or had an acute hydrops, you have injected gas, and that results in cataract formation. So a young patient developing cataract has these two scenarios in cases of keratoconus. In all these cases, when you have a young patient, it's better to put a spherical lens, because these patients are already on GP lenses. These patients are already on scleral lenses. So they are very happy with it. You just clear the visual axis, provide the bulk of the refractive correction by the spherical IOL, and put a GP lens or a scleral lens, and they do very well, and they are very happy.
Sir, how is for the near vision for the child? That is what my question was actually for multifocal contact lenses. Can we fit them like initially when the child is on plain contact lenses, little lens? Later on, can we try for the multifocal if the contact lenses for this child, for this children?
Multifocal contact lens in children, I have not fitted, so I don't have the experience in children. Maybe somebody else can pitch in and give the idea, but I still feel that a case of a keratoconus, if it's a case of keratoconus, wherein you have done a cataract surgery, I don't know. I mean, let's have the opinion of someone else.
So it depends upon how, if it was Dr. Sunandani asking about an aphakic child, if it's an aphakic child and a multifocal IOL, the first thing is the stability of refraction. What is the age? Because the eyeball is going and the refraction is very fast and variable.
So this is a 17 years old male patient, ma'am, who has come.
Traumatic case of Okay, so we did prescribe a multifocal soft contact lens in similar case trauma, and it was a +12 residual refraction with some near addition, because otherwise, or the patient wears a progressive glass over the spherical contact lens which was given.
Actually, the patient was operated somewhere outside New Delhi, and now they have come back for for the opinion for contact lenses or the multifocal IOLs. So that is what I was also, ma'am.
This is one of the best cases of multifocal selection. If Troy and Colin would agree, a young child with trauma and cornea, scleral lens with multifocal is actually ideal if we can fit.
Yes, I would agree. It's the key factor to a scleral lens versus a soft lens, even though a soft lens can accomplish similar results, is the scleral lens masks that posterior surface or the anterior surface of the cornea. That assists a little bit in us kind of relying more on the optics of the front of the lens to correct the issues. And so we have more freedom in creating a progressive pattern, more freedom in creating alternating zone pattern to make the patient happy. But the fact is, I don't believe in that type of patient you're ever going to get 100%. That just isn't going to happen. But at least you can have the possibility of improvement from what they have currently.
Because we do not have high plus powers in multifocal soft lens availability in our country. So we have to give a progressive glass over it if it is available. I think that's similarly what I'm thinking about our patients, young patients, traumatic cases of aphakic. That's ideal for a multifocal scleral lens if we can give that.
No, I just wanted to ask whether the patient is aphakic or the patient has been fitted with IOL.
No. His particular patient is having an IOL, sir.
An IOL, and you said keratoconus.
Yes, sir. This patient was treated for steroid-induced cataract. I think 4 years back. I saw this patient
with keratoconus also.
Yes, sir. The patient has VKC and keratoconus there. So I did a pentacam. The patient was having keratoconus. So now the vision is around 660 with the glasses only. He is wearing some glass. So I wanted to ask that whether we can put the scleral for the betterment of the vision.
It will work.
So I have one question. This is Ritin.
Yes.
I wanted to ask Troy as well as Colin. How is the experience of multifocal IOLs, multifocal contact lenses in patients of keratoconus in general? Like I have quite a few patients who are in their 30s and they've been using scleral lenses now for 4, 5, 7 years, and very soon they'll be presbyopic. So I was wondering if multifocal scleral lenses do well in cases of moderate to maybe even slightly advanced keratoconus, and what's the experience? I'm sure you're doing you're getting a lot of patients of that.
I think patients that have keratoconus, especially patients that have already established in scleral lenses, they can transition pretty well to multifocal lenses. as long as you set the expectation that it's not going to be perfect near vision and it's not going to be perfect distance vision, but the transition as well. But patient education is very important, letting them know that it's not always going to be perfect.
Yeah, and just
Troy,
to,
similar?
sorry, just to key in on that is, Colleen's exactly right. It's the interview of the patient is the most important part and what their expectations are. But creating a multifocal, it should always be known that a progressive is going to be first lens of choice. Progressive is always the best choice for these type of patients. And what we found is extremely surprising. I think initially 10 years ago, nobody would have ever thought to fit a scleral lens with a multifocal on an advanced cone patient or PMD or whatever we have in front of us. But it's changed. What's changed is the ability of the scleral lens to mask practically everything that's on the front surface of that eye. And then what you have remaining is the optics that are on the front of the lens. So the process is starting to become, or at least the knowledge to this point is starting to reveal that it isn't any different than fitting a soft lens when it
So
comes
it sounds,
to trying to
yeah,
correct for presbyopia.
it sounds excellent in theory, but does it work like that in practice as well? Is that your experience? I mean,
It is, yeah.
Yeah, that's amazing.
But that again, that takes it back to Colleen's point. It's, regardless of what patient you have in front of you, whether they're compromised irregular cornea or just a standard healthy eye, it's always about, when it comes to multifocals,
of course,
you have to interview the patient.
Yeah,
you have to interview them, let them understand, because this is not this vision that they're going to get is going to compromise what they're used to. It's not, there's no accommodation this lens is creating. This lens is specifically giving you different light patterns on the retina for intermediate and near in distance. So that has to be addressed to the patient, and they have to understand that, yes, you're going to be able to see your computer better than what you do without. But there's always the possibility in that conversation that we're going to correct you to a plus 150 intermediate, but near, you're still going to have a set of readers with you. That also has to be stressed to them. And again, it's always a compromise. We're providing different points of light on the retina. We're not providing accommodation like they were when they were 20 years old.
One more question. Just one more question to you. I'm sorry, did I interrupt someone?
No, you're fine. You're fine.
Yeah. So just one question. If you're a 45-year-old with, let's say, -7 or -8 diopters of myopia, would you recommend a multifocal lens, or would you recommend a little bit of monovision?
I would probably recommend a little bit of monovision first and then work your way into a multifocal.
Okay.
It's always best to, before you're doing multifocals, to make sure that the fit is established before you order the multifocal. Let them get used to their scleral lenses and get used to wearing them, and then work your way into the multifocal. But for a 45-year-old or a 48-year-old, I think just slightly undercorrecting the non-dominant eye is going to be a better fix.
Thank you, Ritin. And I think we are reaching almost 9. Yes, sir?
I would completely agree with this, that monovision is a very good option. The only thing is that once the patient is used to monovision, the patient will never accept multifocal after that. That is one problem that can happen in most of the cases. I mean, there can be a few odd cases. So that is one thing. But yeah, at the age of 48, 49, I would, definitely go for monovision, and that's a good option.
Thank you, sir. And I guess we'll have to conclude here. It's already 9 p.m. and as I can see, we have almost 100 more questions from the audience here. And I think Dr. Colleen and Troy, I'll email you these questions, and I hope you answer those. And next time when we meet again, I think we can take up the summarized answer to all these questions here. And just to highlight you all, we had 700 plus registration for this contactless webinar, and at this point we have 184 live participants. So it's a huge success for us. and probably the name Dr. Colin and Dr. Troy, that made this impact. Thank you all the delegates for joining us, and thank you all the chairperson, panelists, and discussants. And remember, this is the first of the series. We have 11 more. I hope you all will join us again. Dr. Rohit sir, are you there? If you're there. Rajesh sir, then you please conclude. Rajesh sir is our Vice President of Delhi Ophthalmic Society. So please conclude.
Praful, you have already concluded, and I must congratulate you for a very successful webinar. This was a very nice discussions have happened, and some very pertinent issues were raised. So thanks to both the speakers as well as the panelists, and thanks to DOS, and thanks to the DOS secretary, Dr. Praful Marana. Good night.
Thank you, sir.
Thank you.
Thanks for having us.
Thank you, Dr. Colin and Dr.